Thank you very much. There's a little bit of time for questions, and there are some discussions we can have afterwards. Does anybody like to ask any questions at the moment on that particular topic? If you want to, just come to the microphone. What I'd quite like to ask, actually, and this is for people who are going to start doing delayed enhancement, because it's quite a nice way to start doing cardiac MRI. Do you have a standard dose that you give the patient, and then a standard time you wait, and then a standard inversion time you use to get started for people not familiar?
Thank you for the question. It depends on clinical issue. Sometimes when we deal with acute inflammation, we use early enhancement, and we may start just immediately after contrast enhancement, 3-5 minutes. And another case when we use 5 minutes timing after contrast injection is patients with hypertrophic cardiomyopathy, because different stages of fibrosis are differently visualized at different time points, 5 minutes and 10 minutes. But for patients with post-ischemic fibrosis, usual start time is 8 to 10 minutes.
Thank you. I think, does anybody else like to ask a question? You, please come.
Ask about the previous lecture. Imaging with stent.
Sorry, sorry, I didn't catch that. Can you speak up again?
Regarding the imaging of the stent in the appropriateness criteria of 2010, to image a stent, it must be in the left main coronary artery, and the stent diameter must be above 3 millimeters. But this must be done for asymptomatic patient. My question, why I have to scan asymptomatic patients? Why I have to scan patients with no symptoms?
Yes, point very well made. As a matter of fact, the latest document I've shown you, the one about multimodality imaging ischemic heart disease, says that you don't always have to test patients who have a stent somewhere in the coronary tree if they are asymptomatic. But the left main stent, left main unprotected stent in the left main stenting, there is normally some cautious about it, a cautious approach to these patients, because any minor degree of intimal hyperplasia, if it's causing trouble, and if the patient the patients may develop sudden cardiac death for acute problems happening at the level of the left main stent. So it's a slightly, because of the location which is so proximal at the origin of the left coronary arteries, there is a slightly more cautious approach. So some cardiologists adopt the practice of performing invasive coronary angiography in all their patients if they have a stent in the left main, even if asymptomatic, 6 months after the procedure. Not all follow this, but some cardiologists do. And we are sometimes sent patients with a stent in the left main, although they are asymptomatic.
So the algorithm that I have to scan the patient every 6 months?
Yes, the cardiologists decide when is a good time. It's probably not a good time before 3 months, because it would take at least 3 months for a significant degree of neointimal hyperplasia to develop, but it will be the cardiologist who decides when is the right timing, normally at least 3 months after the angioplasty.
Thank you.
Can I add another point of view to that, which is that most cardiologists consider more than 10% of the LV being ischemic as being significant. If you have a 50% stenosis in the left main, that's a 75% area stenosis. The patient may not have a very large amount of symptoms, but they could have ischemia in 100% or 90% or 80% of the left ventricle, depending on the coronary territories. So therefore, you need to be very cautious about left main stem disease. So if there's any suggestion of ischemia, the clinician needs to know about it, and it's easy patients to scan. It's not a difficult answer, so I would just do it. It's a good thing to do. Anybody got any other burning questions that they'd like to ask? I mean, I have a particular perspective as working I'm a cardiac radiologist, but I support the general radiology on call. And one of the biggest issues we have is trying to persuade my colleagues to use ECG gating for thoracic work, particularly the imaging of people with chest pain. because people seem to be afraid of using ECG gating, but it's actually really dead easy. And I'd just like anybody, if they have any perspectives on this, to please share them with me. But my perspective is that CT is very sensitive and not specific for dissection. We overcall them, and we overcall them when we misinterpret pulsation artifact. And now we can do ECG gated studies of the thorax at lower dose than helical scanning anyway. So we should just get on and do ECG gated studies and make our life easy. I mean, do people here agree with that idea, or would anybody like to offer an opinion on that?
So in general, I agree with you, but I think it depends a little bit on which scanner are you using. So if you have a really fast scanner providing the high pitch mode, it seems to be possible to definitely rule out aortic dissection even without ECG gating. But if we left the high pitch mode beside, I fully agree with you, and it's the same experience in my hospital. It's very, very difficult to convince all the colleagues to use the ECG gating in the suspicion of an acute aortic syndrome. Although it's a very, very stable and simple to apply protocol, but they're still, well, they're not used to use it, and therefore it's still sometimes the situation where we have to repeat the scan because it was not triggered, and I think this is the worst case.
Thank you. So as the moderator, unless there are any further questions, I'll take the privilege of having the final word, and this is that the most difficult thing about ECG gating is finding the ECG leads. Just go and get them from the cupboard, plug them in, and the scanner will do a beautiful thoracic aorta on an on-call situation. Thank you very much.